And that means we can make this available to other families in the future. So here is our agenda for today's session. It's a 90-minute session. So first, I'm going to tell you a little bit more about how the ASXL Rare Research Endowment Foundation works, the resources we have available for families, and how we help connect the professional community. Then we'll hear from our two expert speakers, Dr. Bielas, who is a researcher, and Dr. Wendy Chung, who is a medical doctor and researcher. Dr. Bielas will provide a research update on Bainbridge-Ropers Syndrome, and then Dr. Chung will do a clinical overview. Then we'll move to questions from families that include both clinical and research topics. We'll start with the questions that were submitted when you registered, and then if we have time, we can take some live questions at the end. So the ASXL Rare Research Endowment Foundation was founded by a parent in 2018 to focus on research. Today, we're led by a team of volunteers who are family members, doctors, and researchers, a highly motivated team of people who are directly impacted by ASXL disorders. At the end of today's session, I'll share with you a few ways that you can get involved. So our goal as an organization is to advance our understanding of the ASXL genes, how they work and what they do, and how to improve the care of people with ASXL syndromes. Our mission encompasses the study of the 3 ASXL syndromes: ASXL1, Boring-Opitz syndrome, ASXL2, Shashupena syndrome, and ASXL3, Bainbridge-Ropers syndrome. These genes and syndromes are unique, but they have a lot in common. What we learn about one of them can benefit our universal knowledge of the other 2. The rising tide of knowledge benefits everyone affected by an ASXL disorder. For families, we're excited and hopeful to return to an in-person ASXL Family Conference next year in July 2022 in Los Angeles, California. This conference is a great opportunity to meet other families, talk to researchers, and learn from the world's foremost clinical experts. We will announce the specific date when it's been confirmed, and we hope to see you in California next year. We also offer a resource library on our website for families that includes recordings of past conferences and articles. The resource library is where the recording of today's session will live. One of our strategic priorities this year is to build that library, so please stay tuned for future sessions with medical professionals and researchers. And in fact, I am pleased to announce today a new webinar with Dr. Rosanna Wexberg, who's a clinician scientist at the Hospital for Sick Kids in Toronto. She received an R Foundation research grant to study a genetic aspect of ASXL1 and ASXL3. Dr. Wexberg will share an update on her research and then take questions from families on Thursday, September 23rd at 12 p.m. US Eastern Time. So this is a session that is intended for families. Her presentation will be in simplified terms that you can understand, even if you're not a scientist or doctor yourself. The last resource that I'll mention is not managed by the R Foundation, but it's too important not to share with you all today in case you haven't found it yet. The Bainbridge-Ropers Syndrome and ASXL3 support group on Facebook is a wonderful source of connection and information about life with Bainbridge-Ropers Syndrome. One of the first families to receive a Bainbridge-Ropers Syndrome diagnosis created this grassroots support group. There are currently over 1,000 members in the group. For researchers and doctors, we serve as a point of connection for the medical and research community, both to each other and to families. We host the ASXL Professional Network, a growing network of doctors, researchers, and other healthcare providers who treat individuals with ASXL syndromes. Our goal is to help these professionals talk to and learn from each other. We help fund the ASXL Patient Registry, which is like a library of data and biological samples for families with an ASXL disorder. The registry is hosted at the University of California, Los Angeles, and data is available for free to any researcher who would like to use it. The R Foundation encourages families to join the registry to give researchers the information and biological samples they need. We also fund research grants to advance the study of ASXL disorders. 5 scientists from around the world are currently studying ASXL syndromes with grants that we have provided. Our research commitments total $550,000 to date, and you can read more about these studies on our website if you'd like to learn more. We also host an annual ASXL Research Symposium to provide doctors and researchers with an opportunity to speak directly to each other, to exchange ideas and develop collaborations. This year's symposium will be held virtually in November, and we look forward to an in-person symposium in tandem with the ASXL Family Conference next July in Los Angeles. The in-person events are so special because scientists get to meet families who live what they study. Many scientists report feeling a renewed energy to continue their study after meeting families. So as we get started here, I'm going to launch a poll, and this will give our panelists here a sense of who's on the line with us today. So if you could answer these two questions, how old is your loved one with Bainbridge-Ropers syndrome? And then how long has your loved one had their diagnosis? All right, we have 66 people in attendance here today, so we're approaching 80% of them who have voted. All right, let's share the results here. Okay, so most folks on the call here today have a loved one who's in the 5 to 18-year-old range. Coming in right behind that is the 2 to 5-year-old range. And then as far as length, time since diagnosis, most folks in the 2 to 5 year range, and then another good cohort in the less than 1 or 1 to 2 year range. Great, so thank you for sharing that. And I hope that gives our speakers some context for who's joining us here. Right. So next I'm going to introduce our two speakers, each of whom are experts in Bainbridge-Ropers syndrome. So first, Dr. Stephanie Bielas is an associate professor in the Department of Human Genetics at the University of Michigan Medical School. Research in her lab focuses on discovering the genetic basis of human neurodevelopmental disorders. Her lab identified de novo dominant truncating variants in ASXL3 as the genetic basis of Bainbridge-Ropers syndrome and autism spectrum disorder. Dr. Bielas is on the R Foundation's Medical and Scientific Advisory Board. And next, Wendy Chung is a clinical and molecular geneticist at Columbia University. She is a professor of pediatrics and medicine and the director of clinical genetics. Dr. Chung directs research programs in human genetics of pulmonary hypertension, autism, and birth defects, including congenital diaphragmatic hernia and congenital heart disease. She enjoys the challenges of genetics as a rapidly changing field of medicine. So to start, I'm going to turn it over to Dr. Bielas, who is going to present a research update, and then Dr. Chung will do a clinical overview, and then we'll move to your questions. So go ahead, Dr. Bielas.
Thank you very much. And I hope everyone can see my slides. If you can't, please let me know. But I'm Stephanie Bielas, and I'm an associate professor at the University of Michigan. And today I'm going to give you an overview of some of the foundational discoveries that are being made in ASXL3 research, and then kind of wrap up with some of the outstanding questions and where we hope research will be going. I'm first going to start with kind of a little timeline of how ASXL3 research has started or progressed over the last few years. So it was in 2013 that some of the first case studies were published describing ASXL3 as the genetic basis of Bainbridge-Ropers syndrome. And soon after, large cohort studies, so large groups of ASD patients, there were genetic studies performed on them, and ASXL3 was identified as a genetic cause of autism spectrum disorder. These kinds of genetic discoveries actually have been really important for shaping ASXL3 research because, my lab also was important for actually showing that ASXL3, it says 1 there, is the could actually function like ASXL1 and 2 to deubiquitinate H2A. These discoveries were important because they actually informed the number and kinds of foundations that became interested in funding ASXL3 research and helping to participate in collecting data for ASXL3 research. So early on, Leo's Lighthouse and Simon's Searchlight collected a lot of clinical data, and the R Foundation also was formed about this time, and they are very interested in all ASXL3 genes. And the ASXL-related disorder registry was moved from Cincinnati to UCLA and has been expanding their interest in not only ASXL1, but ASXL1, 2, and 3. Because of their shared interest, there was collaboration across the different foundations to organize the ASXL Family Conference that actually was responsible for bringing many ASXL families together, including ASXL3 families. And this kind of gathering was also important for allowing for samples to be collected and deposited into bioregistries for future research. As Amanda already alluded to, these foundations are also interested in funding research, and over the last few years have also funded the development of reagents to perform research, as well as research studies being done in a number of different model organ systems, including mouse models, human models, and xenopus models. So what is ASXL3 and what is it doing in a cell? And that's a complicated question, even for those of us that are doing ASXL3 research, but I'm going to try and break it down systematically for you here. So in every cell, there is a nucleus, and in the nucleus, there's DNA, and that DNA has to be packaged up so that it all fits inside the very little nucleus. But in order for a cell to develop and function normally, it has to unpackage different genes so that it tells that cell what to become and how to function. And different genes will inform what kind of cell that cell will be. It could be a muscle cell, a heart cell, or a neuron in the brain. And how do cells know how to unpack this packaging to release different cells, different genes that inform the cell's identity? One of the ways that a cell knows which genes need to be unpackaged and which ones need to be expressed is this code of marks on these packaging components. So these little circles and triangles and squares, and how they're distributed across the packaging of the DNA will inform which genes need to be expressed. So this brings us to ASXL3. We know that ASXL3 is actually part of a complex called the Pierre-Dub complex that can change where these little marks are on histones across the genome. And because if you disrupt how these marks are placed, then it can disrupt which genes are being expressed. And in this case, if this N2 gene, we'll say, is a neural gene, it's going to help inform how neurons are developed and how they function. Then you can imagine if you disrupt ASXL3 with a genetic change, then you can disrupt this process. And there have been a number of recent studies funded by many of the foundations committed to ASXL3 research that have demonstrated kind of how this process works. So recently, in my lab at University of Michigan, we showed how this process could be disrupted in mouse brains. And in the Studer lab at Sloan Kettering, they showed how this process could be disrupted in neural progenitors differentiated from, or neurons that have been differentiated or created in a dish, in a human model that can be cultured in a dish. And then the Frank Lab at Technion in Israel, they have also shown this with frog models. And so whether you're while this example is specific for neurons, we know that this process is really important for generating all cells of the body that really impact all organs. And while not every organ is always affected in all developmental disorders, we know that there are many developmental disorders, some described here, and the 3 ASXL related developmental disorders depicted here. We know that you can, if you disrupt this process, you can disrupt the development of many different organs and end up with developmental disorders. And how many developmental disorders are linked to this changing of histone marks or packaging marks really emphasizes that this may be an important area to continue following up on with research. So I think one of the things I would like to emphasize from this timeline is that it wasn't very long ago that we identified ASXL3 as a genetic cause for Bainbridge-Ropers syndrome or autism spectrum disorder. And yet in that really short amount of time, there has been so much commitment and so much organization by families, by foundations, that I think we're already have a well-developed community to support ASXL3 research. So for those families that have been around for participating for a long time, great job. And for those families that are new to the ASXL3 community, I think that you should be encouraged that you're joining a community that's so proactive and interested in ASXL3 research. However, this is just the tip of the iceberg for the kinds of research activities that need to go on in order to really understand the role of ASXL3 research and why it causes Bainbridge-Ropers syndrome. And so I'm just going to end by maybe discussing some of the questions that are outstanding and how we're going about maybe addressing those questions as the research community. So number one, I'm sure many of you are wondering, why is there so much variability between individuals with BRS? And we think that there could be many reasons, but it will be important to really try and understand if there are differences in the different ASXL3 changes that are being identified in different individuals. So we know that even though there is a growing number of children with ASXL3 variants, there's a lot of variability. So here you can see a lot of children experience a subset of these clinical features like global developmental delay, autistic features, but then they have variability in how many of the other features that they exhibit. And this is complicated by an ever-growing number of variants. So here, all of these different little triangles, squares, represent a number of different variants that have been identified in different databases. But there isn't a clear genotypic phenotypic correlation. There are some ASXL3 changes here that give mild phenotypes and some that give severe. And the same if you're getting a variant in another portion or a change in another portion of the gene. One of the ways we think that we may be able to investigate this is, so far, we've created quite a few different mouse models between different labs and even biotech companies such as Regeneron. And when we create mouse models in different areas of this gene, so they have changes, genetic changes that look like a patient's ASXL3 change in any one of these different regions of ASXL3, we see a lot of variability in the mouse models. Some mouse models have no features associated with ASXL3, and some of the mouse models have features even more severe than ASXL3 patients. So we think that these different lines may help us dig down and understand why there are differences. In addition, many of you have already participated in research and given blood samples and skin biopsies, and those are really valuable resources. And whether you're participating in the Biobank at UCLA or the Simons Foundation with Simons Searchlight, all of those samples are really important, and they come from individuals that actually carry these kinds of different changes, genetic changes in ASXL3. And we can make cells that we can grow in a dish. And then we can start to investigate, is there a difference in the ASXL3 that has this change versus this change? And we think that this will be really important for understanding why there is variability. So one of the next important questions, I think, for the ASXL3 community is, what is the impact of ASXL3 developmental changes on behavior and function? So I suggested that there have been mouse models, human models in a dish, and xenopus models that suggest that there may be changes in neuron development or the cells that make up the brain. But while we have information that if you disrupt ASXL3, it can change genes that inform how a neuron develops, ultimately, it's the neuron and its synapses, the connections it makes to other neurons in the brain, that are important for how they affect our cognition and our ability to function. And so it will be really important in future to understand how ASXL3 may alter the activity of a synapse, or how overall it may change the behavior of, say, a mouse. And these studies will be important for maybe understanding how ASXL3 is actually changing a neuron in the part of your brain that controls language, or in a part of your brain that might lead to seizures, or in a part of your brain that controls how you sense pain or how you move your muscles. And so I think that there are many exciting future studies that can be done in this area. Another question is, it's not really a question, it's just an urgent area of research that will need to be done. Well, I have kind of talked about ASXL3 research from the context of a brain. We need to understand how ASXL3 may be disrupting other organs and why there are feeding difficulties, or why there are issues with digestion, etc. And then once we understand what our model systems are telling us and how they really inform us about ASXL3 in patients, then we can try and start to understand if we can reverse some of the bad effects of ASXL3 that's been changed in patients. And can we design and test therapeutic options that might actually allow us to make changes that reverse the effects of ASXL3, changes in ASXL3, genetic changes in ASXL3. And with that, I think that while we we're off to a good start. I think that these are some really important questions that will keep us busy well into the future. And we're eager to have both participation from families committed to research, as well as attracting additional researchers to help perform this long list of research that needs to be done. And just to kind of throw research opportunities out there, there is becoming more clinical data available out for clinicians to deal with ASXL, to understand how to treat patients with ASXL3 research. But we're really interested in also potentially developing this composite of the ASXL3, the Bainbridge-Ropers Syndrome face. And so to do that, we need pictures from a number of individuals with ASXL3 changes. And if you'd like to participate, you can find my website by searching Stephanie Bielas at Michigan. There is a Bielas lab at University of Washington, just to throw that out there. And then you can click on participate in research. And with that, I will take any questions when we open it up for the panel discussion.
Great. Thanks, Dr. Bielas. So we're going to hand it over to Dr. Chung now to do a clinical overview. And then, as Dr. Bielas said, we'll take questions after this presentation.
Thanks, Amanda, and thanks, Stephanie, for introducing all of this. So I had a chance, Amanda was kind enough to provide a preview in terms of the questions coming out from the community. So I'll try and address many of those questions as we go through, but if I don't do it quite right, you'll have lots of time at the end. We're saving time for Q&A. So I'm presenting some of the work that comes from, Stephanie referred to it already, Simon Searchlight. I put the URL up here for anyone who hasn't heard about this, but also to say, as Stephanie said, she's collecting data, also Dr. Russell at UCLA is collecting data. And just so the community knows, all of this information is freely available to the researchers that you're seeing today, but also to the research community at large. So we want to make sure that we're trying to minimize the work that you have to do and maximize the effectiveness of what you're doing. All of this is free to the research community and funded by the Simons Foundation. So the reason I say that is it's going to be here forever. So you don't have to worry that the data is going to disappear or that it won't continue to be supported by a grant. It's here for the long run. What we're doing in terms of this, and as I said, anyone can go to that website to be able to register. It is what we call a longitudinal study. So it's not just a one and done, but it is understanding how this changes over the life course. And I will tell you that one of the things you're going to be seeing a survey come out about is trying to understand what families think is most important as we start thinking about clinical trials and as we start thinking about outcome measures and the things that are most important to you. This is an umbrella, if you will. It's not just specifically for Bainbridge-Ropers syndrome or for the ASXLs, but for about 160 conditions, genetic conditions, all associated with autism and neurodevelopmental disorders. So it's part of a larger community and trying to be able to, as I said, have an economy of scale to be able to work across conditions for researchers who are interested in these types of things. It is open to families internationally. So for those of you who may not be US-based, that's okay. We do have a team that's international in terms of languages that they speak, so hopefully making it more accessible to more people to be able to meaningfully participate. As we do this, I put up just a list of what we do so that you have some sense if you join. Again, you don't have to do everything. You don't have to do it all at one time. But what I'm going to be showing you today is based on these data. For anyone, for instance, who had their genetic testing, but in some cases, I know parents weren't able to get testing or siblings weren't able to get testing. One thing that we do offer through the study is free testing for those other family members if it's helpful in terms of either interpretation of the variant or just to be sure that someone doesn't have it. So that is something that's free, and we have a way of being able to get in those samples, as I said, from around the US as well as around the world. So again, I'll be talking about all of this information. So Stephanie already gave a similar representation. This is just a stick figure of the gene and some different domains that are important. But for those of you who are scientists that are, or clinicians that are looking in, most of these we think of at least predicted to be what we call disrupting one of the two copies of the ASXL3 gene. Importantly, that still means there's one copy of the gene that's intact. And I think many of us think that's important in terms of a potential strategy. One could think about longer term if there's some way of turning up the volume, if you will, for the remaining copy of the ASXL3 to be able to compensate for the copy that is not functioning correctly. But as you already heard, and I hope you can see my mouse, the variations that we see are scattered throughout the gene, and whether or not this sort of disrupts one entire copy or whether it makes a fragment of a protein that may have something else. I think some of us have ideas, but basically I think most of these we're assuming that we've got 50% of the amount of ASXL3 that's working, and that many of these are probably acting by similar mechanisms. As was described already, though, there is some variation between individuals. And so I'll just amplify one of the comments that Stephanie made. It's really important that every single person is represented. And so I'm going to say that one more time, because you'll see that the genetic variations, although these lollipops, when they're on top of each other, mean that this same variation is carried by multiple people, you'll see that almost everyone is unique here. And the differences that we see in terms of manifestations, we don't yet understand the differences. But I'll tell you, there may be something that one of you has that holds the secret in terms of either something that's helping to compensate for the change we have or the variation we have in ASXL3. And by being able to study, for instance, cells that are from such individuals, it might hold the clue in terms of the rest of the community. And we just don't know where those insights are going to come from. So I do encourage everyone to be represented. As we're doing this, when you are represented with any of these biobanks that the researchers have been talking about this morning, it allows you to be represented when it comes forward in terms of ultimate understanding and hopefully someday treatment. And so I urge you, it's not that hard, but it's a big multiplier in terms of what you potentially could get out of this downstream. I don't know where the answer will come from, but potential that it will come downstream. So I'm going to dive into the information we know about individuals, and I'm going to put some limitations on this, that we don't know everything, but I do think we know quite a bit. So these are all data that are coming from Simon Searchlight. Each individual, just for the researchers out there, has been verified in terms of reviewing a clinical report, and they all apologize about the gobbledygook, but these variations have been certified to be pathogenic or likely pathogenic, so there are no variants of uncertain significance represented here to hopefully give a clear picture of what Bainbridge-Ropers syndrome is, at least within this group. Now, what are the limitations? I've shown you a distribution of age. So on the x-axis here is shown buckets of age. So the little ones are on the left, age 1 to 3 or 4 to 6. Older folks over here on the right, age 22 plus, and over on the y-axis here is the frequency or the number of individuals in these age buckets. So one limitation is this represents 41 individuals. So I think that's a good representation, but it's not 400 individuals, so realize that. And it also is skewed more towards the younger individuals. And in particular, some of you had questions about longer term, what happens when we think about young adults or beyond. And I do think we've got some limitations in our understanding of that. It's not that I don't think folks are out there, but I think in terms of the bias of who's been getting genetic testing, we're definitely biased towards children at this point. I will say internationally, I'm very happy to say that many of us in the genetics community have been advocating, not just in the United States, but I know in Germany and the Netherlands and France, in terms of making universal access for the types of testing that you need to diagnose BRS. And in a good way, in the United States, there's now guidelines that are actually recommending this type of testing of exome sequencing, and that's also going on internationally as well. So we've been getting about 1 per week in terms of new community members. I actually expect as we're coming out of COVID and as more and more people are adopting these guidelines that we've written, the numbers are going to go up substantially. I think the condition is much more common than we appreciate. So I expect, I don't know what our final numbers will be, but I think we'll actually increase significantly. So the next few slides are broken down by different types of manifestations, and I've tried to include the frequency of these different things. These numbers or these percentages are shown over here on the right, and all of this information will be available after the conference. So don't feel like you have to, scurry and write down all of the percentages exactly. The condition I would characterize as mostly above the shoulders, in the sense that I think it's mostly a brain and behavior condition. The other point that I'll emphasize, just to make sure you get the take-home point, is that it seems to not be a progressive condition. So what I mean by that is it doesn't regress, things don't fall apart. From a developmental point of view, things are slow. Definitely, I think all of us appreciate that. They're slower than they are for a neurotypical child, but they continue to move forward. And I think the thing that we're all trying to figure out is, what are the best practices? What are the best therapies, educational strategies we can use to make that slope as steep, as sort of rapid as we can in terms of how children learn and how they're able to acquire new skills. Stephanie mentioned this earlier. It was on her sort of rainbow colors shown in terms of frequency, that almost everyone has some degree of either intellectual disability or developmental delay. I'm going to use those words a bit interchangeably. There are some technical differences, but the point is that it takes longer for children to be able to learn new skills and really solidify those skills as they're going along. A significant fraction, I would say it probably varies between about 25 to 40% of individuals have either autism or autistic-like features. And I'm not going to parse this too much in terms of the differences, but these are issues in terms of feeling more comfortable with routines, being able to know what to expect, sometimes getting anxious if they're not like that, sort of feeling off your game. And on the other hand, I will say that from my own personal experience, individuals are wonderful in terms of social connectedness. So it's not so much that aspect that I see in terms of the autism, but some rigid behaviors and some need for consistency, I guess, is the thing that I see most consistent with autism. Many people were asking about this, but language is definitely delayed. Some individuals will remain nonverbal over their life course, but I will say that I think individuals understand much more than I think we appreciated before. So in a good way, and I think I've seen this in looking at those over age 20 versus under age 10, as we've developed new technologies for communication, as I think we have increasing access to early intervention and speech therapy that's coming on earlier, we're seeing individuals able to process quite a bit and use, in some cases, as a bridge to speech, alternative methods of communication. So whether these are communication devices now on an iPad, whether they're gestures, whether they're signs, whether they're picture cards, but other things that help us to understand that they're understanding, they're processing, they're able to get their ideas out. But the simple mechanics of literally being able to coordinate tongue, lips, throat, all of the things that you need to do to be able to speak clearly and articulately, that takes some time to come in. And it may be quite a while for certain individuals, but like I said, it's not because the thoughts aren't there and they're not processing things. So be careful what you say as you're thinking about this. And as I said, I do encourage you to push your speech therapist to think about alternative methods of communication as a bridge. Don't give up on speech, but use it as a bridge so that folks can be able to express themselves. We do see a few other things, like I said, a need for sameness, some anxiety when things aren't the same, and problems with attention. And I'll just say as a general, I think, global statement that with COVID, and we've done surveys to see this, with COVID, I think our children took a hit in a sense that their lives were disrupted even more than some others, in the sense of not being able to be in person for some of their therapies. Although we're on Zoom now, the idea of trying to do a speech therapy session on Zoom with a little one is not very effective. And so I think we've got some catch up to do as people, hopefully many have gone back in person, even in the last 6 months, but as things are normalizing, hopefully things will get even much more normal. I'll just interject one more thing about COVID since I said it. I get a common question in terms of either the vaccine or the infection, how are our kiddos doing with COVID? We've done, again, surveys to be able to understand this, and the good thing in general is that children in general are pretty resilient when it comes to COVID. Some people know there have been some issues in terms of was kind of for a while this inflammatory syndrome that happened in the very early days of COVID in a very good way. We as pediatricians have figured out how to treat that with some steroids and what's called intravenous immunoglobulin. And so those children are doing very, very well, not just children with BRS, but children in general. And in general, the sort of severity for those infected has been relatively mild. And this continues to be the case even for children with neurogenetic conditions. In the United States, at least, we are vaccinating children aged 12 and up. And I strongly recommend vaccinating our children as well as their household family members to prevent transmission within the community, because although it isn't a severe problem in terms of death, anything that holds our kids back is certainly, it takes its toll in terms of getting them back to normal, whether it's with feeding, whether it's gastrointestinal upset. So the more that we can keep things stable for them, the better it is, I think, in the long term. In terms of thinking about some other things related to the brain, I won't focus too much on the things on the top here, but we do have problems with both hypotonia, that is low muscle tone, as well as hypertonia, high muscle tone, or tightness or spasticity. For some individuals, this varies by part of the body. For some individuals, it varies by life course and over time. But I will say one of the important things to me from a physical therapy point of view is that some of the kiddos that are hypertonic can get contractures if we don't keep them loose and limber with physical therapy. So it is important to be able to keep them at their best, because if they do get contractures, problems with movements and walking can become more problematic. So I will point out this one in particular. The other point that I'll make on this slide is it's not the majority, but a small number, or a little less than a quarter of individuals do have problems with seizures. In general, the seizures are not a terrible, terrible issue in the sense that they usually are treated with medication fairly well. But it is important because if individuals are having seizures and it's not treated, it certainly can hold them back in terms of their brain function and their learning and being their best. The other thing that I'll point out is that about half of the individuals who have seizures can have subtle forms of seizures that we call petit mal. What this means is, for those of you that might see someone with it, it kind of looks like they're staring off into space. It looks like they're just sort of not present, not with you for a brief period of time. They don't last hours in this, and then they can come back. Sometimes they're hard to recognize, I'll admit this. And so if you're concerned about this, if you have the ability either for a petit mal or a grand mal, something that's associated with jerking movements, I urge you to, number one, make sure your child is safe. And if you do have especially a second person, have them take a videotape with their phone or some other device, but usually it's my phone that's handy, and share that then with your neurologist, your pediatrician, whoever your doctor is taking care of your BRS family member. And they can oftentimes just have a sort of other experienced set of eyes to decide whether it's worthwhile doing an electroencephalogram or an EEG to formally monitor for seizures. And we usually do that in the hospital overnight if there's enough reason. Again, it's to me, a significant enough fraction of individuals with epilepsy, with seizures, that it is worthwhile if erring on the side of caution. So in other words, if someone's not quite sure, it's better to be sure and go ahead and do that EEG. And I prefer doing it, as I said, in the hospital with a video recorder going at the same time, so that if you're seeing something, you can push a button as a parent and say, timestamp it and say, this is when I'm seeing Joey staring off into space. And then the doctors can look at the same time on the EEG pattern to see whether or not there's any electrical activity that corresponds to that. So in addition to that, one of the other more common features, still not the majority, but more common features are issues with the eye. The reason I bring this up is it's in part a safety issue and a learning issue, both of those. So The eyes are the windows into the brain. And so what we're doing in terms of observing and understanding our environment, the eyes are incredibly important to take in your surroundings accurately and to be able to just see where you're going, not bump into things, not fall, not trip, not fall down the stairs. And that's why I mentioned from a safety issue, it's important to me that the eyes are working as well as possible, as well as I said, learning as much as you can about your environment. With this, some of these things are relatively easy to spot. So if you're seeing a lazy eye or a cross eye, in other words, the eyes aren't lining up straight ahead, then it looks like maybe one's wandering off to the side. That's something that oftentimes you and your pediatrician will see right away, and you know to go to a pediatric ophthalmologist. You'll hear me sprinkling in some recommendations. I can't guarantee that all of you will have access to this, but when it's possible, it's best to see a pediatric ophthalmologist for children with special needs. They're more equipped to be able to handle some of the subtleties. You know, for instance, our kiddos aren't going to read an eye chart and be able to call out letters and, you know, say what letters we're reading on what line. And so you need someone who knows how to deal with children with special needs, not just to see things like a lazy eye, but we also see some problems that can be being able to see far away or being able to see near. And in some cases, just being able to have the facilities in terms of children that may be, you know, not feeling so comfortable if we put drops in the eye or if we shine the lights in their eyes to be able to see things well. Again, this happens frequently enough, and I would say oftentimes needing surgery if patching doesn't work to be able to clear this up, that it's important to go to a center that's experienced, hopefully at least with children with special needs, if not children specifically that might have BRS. Thankfully, again, these are oftentimes things that can be treated, and so we want to especially make sure we don't miss things that we can treat. One of the other big issues, and I know many of you had comments about this, are just tummy troubles. So the tummy troubles, and Dr. Bielas, or Stephanie rather, referred to the fact that within the intestine, there's in part signals from the brain that are going to the intestine. And there's even, I think of it as the brain in your gut. So there are neurons that are in the intestine that are doing things like determining how quickly the muscles contract in the intestine. In some cases, when they contract very quickly, it can lead to diarrhea, or when they're not contracting so much, can lead to constipation, or when muscles are weak, can lead to what we call reflux or heartburn, with things coming back up from the stomach and, you know, sort of floating upwards. So all of these things are very frequent. I would say the good news for those of you who have younger children is many times it will get better with age, in part because we figure out what the problem is, in part because we figure out the right treatment for it, and for some kids because they tend to get better and outgrow some of these issues. But whatever it is, if the tummy isn't happy, the kids aren't happy, I guess is the bottom line. And so it can help them in terms of just being uncomfortable, not being at their best to learn. But there aren't really any magic treatments within this. And I would say this is largely true from a medicine point of view for almost everything with BRS. It's a little bit of trial and error. A good pediatric gastroenterologist can be extremely helpful, but it's a combination of diet, and it's a little bit of trial and error in terms of the family member in your family. If there's lactose that bothers them, you know, and for some people, lactose or dairy products help in terms of keeping things regular. For other individuals, it leads to upset. And I can't tell just by your ASXL3 variation which it's going to be. It's a matter of trial and error with those things. In some cases with the constipation, and I know this sounds like an old wives' tale, but prune juice really can help some people. So whether it's prune juice, whether it's some fiber supplements, but there's some other things that many of us use just for constipation in general that can be useful as well. Things like the reflux, though, oftentimes take medication, and it's not a big deal. So it's not, those medicines are very inexpensive, very easy to use, not dangerous to use, but it is a little bit of trial and error in terms of this. I would suggest if you're at that trial and error stage within your family, whatever you try, I would give it a good 3 or 4 weeks to try it. Keep a little notebook, an Excel spreadsheet, however you want to do it. But when you do something, just make a note of when you do it in your own notes, your own sort of diary or log about whether or not things are getting better or worse, but give it the old college try before you give up, because sometimes it takes a little while to adjust. The other thing I'll say is that if the children are treated with something like antibiotics, so if they have an ear infection and get antibiotics, that antibiotic oftentimes will wipe out the microbiome, in other words, the little bacteria that live in all of our intestine. And when they wipe it out and they're repopulated, when they grow back, they don't always grow back the way they were before. And so again, talk with your pediatrician or gastroenterologist. Sometimes we'll actually do some additions where we'll add back some of those good bacteria into the intestine to hopefully repopulate things and get things back to the balance where they were before. But when possible, I do urge not to use antibiotics frivolously, because that can be one of the complications afterwards. So for instance, with COVID, I don't treat those with antibiotics because they don't work. And so don't think that every sniffle you need to use antibiotics. Over time, and I especially see this when the children get a little bit older and in adolescence, we can have some bone issues or orthopedic issues. And scoliosis, again, remember what I said about the constraints, that the population I'm showing you today is largely under age 10, but we were starting to see when the kiddos were starting to go through adolescence, the curvature of the spine or scoliosis could be an issue. This is generally true of all children that have neurogenetic conditions where hypotonia is associated with that. And it just becomes something that sometimes you can brace. You know, it doesn't necessarily need surgery, but things that can be braced. What I do think is important, though, is some of these orthopedic issues, and this is whether it's of the back or sometimes of the legs or the ankles. If you don't get things straightened out early, they can be progressive. And so kiddos, especially if they're not moving so much, if they're sitting a lot and kind of hunched over, the scoliosis can continue to get worse. And if it does get to the point of surgery can be extremely disruptive just in terms of recovery back from that. So we try and keep on top of this as much as possible. Another very common question is about growth. So this is a sort of associated with the intestinal issues. And again, in a good way, as we figure out how to feed the children, get enough nutrition, the right calories into them, they do tend to respond to that. But oftentimes early on within the first year or two of life, it's a struggle. And I totally understand. For those of you who have parents of little ones, especially new to the community, it is challenging. So challenging, in fact, that we sometimes have a bypass in terms of sort of the usual way of getting food in. So you'll see if you've talked with other people, whether it's a nasogastric tube, whether it's a gastric tube going straight into the tummy, we sometimes need to do that to be able to get the kids the nutrition they need. When they get the nutrition they need, they obviously grow better, they're stronger, they're more resilient with fighting infections, they do better with their therapies. So it's a really fundamental, important thing to make sure the kids are getting the nutritional support they need. With this, though, they're likely not going to be giants. So with BRS, they tend to be on the smaller side. At some point, I hope we're going to have some BRS specific growth charts. Someday that's one of, I think, our fantasies, is to know what to expect in terms of that. And we're getting there. But in terms of growth hormone, which is a common question, can we just take care of this by doing some growth hormone shots and making things better? That won't necessarily fix the whole problem. The problem is not due to a deficiency of that growth hormone. It's a problem in terms of essentially the blueprint for how individuals are programmed to grow. And so I wouldn't urge you to, go out to an endocrinologist and try to get pumped up on the growth hormone. I would, though, in terms of recommendations, like I said, if you do need to use something like a nasogastric tube or a G tube, don't give up on feeding at the same time. If your child is aspirating, or if the nutrition is going down the windpipe instead of the stomach, do talk to your doctors about whether it's safe to give food by mouth. But if it is safe to give food by mouth, then I would suggest, in combination of getting that nutrition in, don't give up on feeding by mouth. Those same oral motor skills that are being developed in terms of chewing and moving things around the mouth and swallowing are some of those same coordination and motor skills that are necessary for speech. And so by exercising that, you're actually setting up in terms of being able to do speech. And long term, we want our kids, if it's possible, to be able to eat by mouth. If it takes a while, that's okay, but that just helps in terms of daily supports. So I made a brief slide about the medications that we've seen currently being used so that you had a sense of how serious or persistent these things are. As you'll see, in a good way, everyone doesn't require medication, even for the tummy troubles. But there are, the top of the list are those tummy troubles. Again, epilepsy, about a quarter of the community, some of the behavioral issues, some everyday pediatric issues like asthma, and then there are some issues, the antidepressants, the cannabidiol are used for behavioral issues, and those tend to, I see, be more frequently once we get over age 10 and into puberty. So I know there were questions about the recommendations. At this point, we don't have a what I call standard of care document. I think that's something that as we get a little bit more information, we're getting close as to being there. But I did put in red this place called Gene Reviews, and you can Google this if you like. And I definitely recommend that as you go to your child's doctor, if your child's doctor says Bainbridge who, and they have no idea what you're talking about with this condition, you can actually take a printout from the Gene Reviews. It's free. You don't have to pay to be able to get into this, but go to Gene Reviews and type in ASXL3, and up will come up what are the current understanding that we have as a community. And it's actually meant, I'll warn you, it's meant to be for physicians in the sense that they can read it relatively quickly, think about where their patient is along the age spectrum, along the diagnostic spectrum, and then be able to think about what they need to do at that visit. So it is the closest that we've got, at least that I know of, in terms of a standard of care or recommendations. I think it's helpful in terms of giving your, again, whether it's your pediatrician, ophthalmologist, dentist, whoever it is, be able to give them some guidance. And these are my recommendations. So I will warn you, these are the Wendy Chung recommendations. I don't know that Bianca Russell will agree with me or someone else, but I think we're probably on the same page. And with this, the recommendations come for the earlier the better. So what I mean by this is early intervention from the time either you've had the BRS diagnosis or even just suspicious that something's going on. I think most of you have already done this, but making sure that you're getting multimodal therapy. So what I mean by that is physical therapy for the big muscles, occupational therapy for the small muscles of the hand, speech and feeding therapies. And I will warn you that sometimes this takes a while, so be patient. And then ABA therapy is what we do for individuals with autism. And I actually think ABA therapy helps for individuals, not just with autism, but I actually think the strategy, the teaching strategy, helps for anyone with BRS. As we're doing this, I talked about this a little bit already, but treat the tummy troubles, be patient with the feeding, and make sure that the nutrition is good. Make sure that you're seeing the eye doctor, making sure you're seeing a pediatric neurologist at least once for an evaluation. I do think it's important to see someone at least once, and then monitoring those bone issues or orthopedic issues over time. So again, this is just a final summary in terms of all of the things that we see. In terms of speech, I will say be patient. I am actually seeing that the current group of children coming up, as I said, I think are doing better. So be patient and don't give up. That's one I think important thing that you should hear from us is don't give up. It takes time, but be patient. And in the community, I do think that community in terms of BRS community, as well as your local community, whether you're in Spain or whether you're in Brooklyn, it's tricky, but you do need to find providers who are really good at being able to treat. It doesn't have to be BRS, because you oftentimes won't have a provider who's a BRS expert in your backyard, but you need to find people that are willing to learn, willing to be able to listen to things like this or read, the Gene Review summaries, and are willing to be able to be patient and to work with you and to take your observations seriously. So if you can find those types of providers, whether they're therapists, whether they're doctors, but find those people in your local community. Again, they don't have to be BRS specific, but individuals with special needs and dealing with children with special needs are oftentimes what you're looking for with that. So I just have a couple more slides now focusing on people had questions about sort of what to expect in terms of, you know, is my child going to be living alone? Are they going to be walking or talking, or when might these things happen? So I'll warn you that one of the things that we're doing, at least in Simon's Searchlight, is we're asking people to fill out some of these questionnaires online every single year, because we're developing what I call a developmental growth chart. So we're trying to get an answer to your questions about, my child's kind of going at this pace, what can I expect for them when they get to be 10 or 20? So I don't have the growth chart all done yet, because we still need to get that, what I call longitudinal information over time. But we do have some of the information. So this is, some of you have filled out something called the Vineland Adaptive Behavioral Scale. And this is simply to show you that our kiddos are below average. We all knew that. 100 is average here. There's a distribution, I think, is the point that some people were making. And so there are some individuals who are, for instance, this over 70 is still considered within the normal range. And they're a small number, but a few people who are in the normal range. They're verbal in terms of what they're able to do. They're able to do much more in terms of self-care skills, things in terms of everyday life, being able to be more self-sufficient. On the other hand, we have some kids that are, for instance, below 40 or 50 who are more severely impacted in terms of not being verbal, in some cases not even being mobile in terms of getting around, and definitely not being able to help in terms of their self-help. What people were asking about is, how can I tell, for instance, if my child is 2, are they going to be at this range or this range? And that's what Stephanie was saying in terms of, in some cases, we don't know. We don't understand the differences in terms of whether it's something we do with our interventions, if it's something about the genetics, either the ASXL3, I just realized I have a typo there, but, or if it's something in terms of other genetic factors that might be influencing ASXL3. In addition to that, we also have something called the Child Behavior Checklist, which is getting at problems in terms of sometimes aggression, being able to have things like temper tantrums or things that might be self-injurious behavior. And simply to say, in terms of this, the majority of individuals don't have those types of behaviors, but we are seeing a little bit more either getting into the borderline or getting into the concerning range as kiddos are getting older. And I think puberty is one of the times when we're looking very closely to see how much is changing with those change in hormones. So I put this in here. I think all of the investigators, the scientists on the line know about this, but just to remind people, any of these data are available through Safari Base, and there's a big team of people that are behind the scenes helping everyone to make all this happen. So I'll stop there.
Great. Thank you so much, Dr. Chung. That was a wonderful overview. So we'll move now to some family questions. So the first one that we'll start with is, what advice would you give to a newly diagnosed family?
So I guess the advice I would give is be patient, don't give up. And there are a lot of people there to help you, both in terms of understand the condition and what I would call sort of news you can use. So everyday tips or things that are life hacks, you know, are different things that I think of, but things that are just really, really practical. And I'll be totally honest, the other families in the community are much more useful to you for some of these things than doctors like we are or researchers like we are, especially all those really helpful life hack things. So, you know, if it's like, my child is having sleeping issues this month, and, you know, like what's going on with that in terms of the sleeping? Sometimes, you know, I can tell you, well, you know, melatonin might work, or here are some of the things in terms of sleep hygiene you can try. And then sometimes I have parents that are just brilliant, and they can, you know, they've tried something, or they've tried a certain something in the diet, or they've tried a certain type of, you know, adaptive device in terms of, you know, physical therapy, or their physical therapist has come up with some contraption in terms of starting to learn to walk. And it's really helped accelerate, you know, those early steps, literally, in terms of learning to walk. So I just encourage you to, you know, help each other, I guess is one of the points, but don't give up and don't underestimate your kiddos is the other thing I would say. Is there's just a lot of potential there that I think, and I think it's been our bad that we haven't done a good enough job of listening and learning from our kiddos in terms of what they were capable of doing. And I fully believe they're capable of doing more than we allowed them to do sort of in the last generation.
Yeah, I also think if you live in a slightly bigger city, then if you can connect with other families that have children diagnosed with Bainbridge-Ropers syndrome, maybe see if you are able to see a clinician that is seeing more than one Bainbridge-Ropers syndrome patient as well for a particular feature, either neurology or GI, then that helps give that clinician even more perspective on potentially what's something to consider, or they've already identified a couple of strategies that might be effective.
Thank you. All right, so the next question is more of a genetics question. So why is ASXL3 mutated in the first place? Stephanie, go ahead.
Go ahead, Stephanie. Yeah, go ahead.
I think that genetic changes are unbiased. They randomly can, of course, there are some places in the DNA of every cell that they like to make changes more often, but I think the whole, all the DNA in our nucleus is fair game for genetic changes, and it's just random. It's oftentimes the fault of no one. It's just by chance. It happened in ASXL3, and there different kinds of changes happen, and I don't think anyone's at fault. It's just the luck of the draw.
So I think a good follow-on question to that that someone posted in the chat is there a risk to future pregnancies if you already have a child with Bainbridge-Ropers syndrome?
Maybe I'll take that. So I want to underscore what you just heard. This is no one's fault. This is not something that you missed a prenatal vitamin, that you had a glass of wine before you realized you were pregnant. This is no fault in terms of anyone doing this. And we all, just to emphasize, because this answers this question, these genetic changes are almost always brand new in the child with BRS. So it's not something that gets passed down from parent to child. I'll give you a very small exception, but almost always that's the case where it's something new in the child. The exception is the answer to this second question, and that's that there are a very small number of parents who are what we call mosaic. So, and in some cases when we do the test, we won't see that because they may only have a small number of cells in their body, in the eggs or in the sperm, where more than one of those cells have the change. And that's the only way that we know of where this can happen again. Otherwise, lightning doesn't strike twice. You don't end up, having two children with BRS unless one of the parents is a mosaic. But when we do those blood samples or cheek swabs that parents usually get for the testing, we're not directly testing the sperm or the eggs. So we may not appreciate that they're a mosaic, even though they are. So when we generally look at these, and when we look at literally thousands of families in this situation, the chance that this happens again is usually about 1% if we don't see evidence that one of the parents is a mosaic. So 1%, I guess it depends on whether you feel like the glass is half empty or half full, or 1% full or 99% empty. To me, that's a good, it's good and reassuring to know that it's very unlikely it's going to happen again if you've had one child with BRS, but the probability is not zero. And so for some families who feel like they want to be 100% sure, absolutely be 100% sure. You know the exact change in ASXL3 in your family, either after a baby's born, if you want to double check, that's fine. While you're pregnant, if you want to double check, that's fine. In general, I don't suggest that people do assisted reproduction or in vitro fertilization. In general, the chance that that's going to happen is so low that this is just my opinion, that given the expense, the sort of trouble it takes to go through that, that's usually not something my families have found useful.
Yeah. All right, the next, it's two questions together here. These are both about seizures. So the first half of the question is, what causes seizures, and is there any way to avoid them? And then the other question I'll tack on to that is someone who asks about seizure regression. Her daughter grew out of petit mal seizures. Is there a possibility that she could have them again in the future?
Yep. So what I'll say is in terms of seizures, again, the majority of individuals don't have seizures. I will say I always worry about puberty as a time when things can happen again with the hormonal changes and the other changes that are going on in the body. The other thing that can happen is with fever. It's not necessarily that it's epilepsy, but the fever itself can sort of kindle sometimes a seizure. And so you may have technically a febrile seizure that can be associated with that, or if someone should be unfortunate to have head trauma, really get a good bang or bop on the head, then those are things that can sort of, again, interact to bring a seizure out again. I do know of individuals who have outgrown their seizures and been able to get off medication. Obviously, you want to be in very close sort of care with a child neurologist who can be able to do the EEGs and monitor and make a recommendation for your specific child. Again, I'm not giving out recommendations for any specific person to now, just ditch their seizure medication, but do talk to your child neurologist about that, because I have sometimes seen that happen.
Thank you. So the next question is there any advice that we can pass along to educators to better aid our kids?
So I guess what I would say in general, and this is different school districts, different countries have different options in terms of things. I do think the kiddos do better in terms of a smaller classroom size. So in terms of, whether it's 4 to 6, I think is my preference, at least in terms of how small you can get the classroom size. I do think it's important, though, that they're exposed to neurotypical children in some way, that they're not just totally exclusively segregated. So however that happens in your community, in your school district, I think there's some combination. In general, the other thing I'd say about the small class size is that kids learn from each other. And so when it's an option, you don't want them in a class where they're going to be at the low end or the high end of the functional scale. So you want them to kind of reach to be able to mimic what the kids that are maybe a little bit ahead of them are doing. You also want to be careful that they're not in a classroom, if you can, where they're going to be learning a lot of bad behaviors and mimicking those bad behaviors. So things that might be, in terms of especially tantruming or what we call externalizing behaviors, you want to try and, right size this. I realize there are limitations in that, but for me, that's been optimal when you can think of that class size. And you want some one-on-one attention, right? It takes a lot of repetition in terms of solidifying these skills. You want special educators that are really patient and willing to, again, be creative and work with you.
Thank you. So next question is for Dr. Bielas. So how optimistic are you about where your research is going in the next 10 years?
Very optimistic. I think that there's so little known about ASXL3. So anything we do is really just telling us gobs of new information. And then we're always committed to putting it in context or understanding it in an in vivo system versus an in vitro, in a model system that is a whole organism or in a cell in a dish. And so I think that not only are we identifying interesting things about ASXL3, but we're very fortunate in that we are relatively quickly getting access to patient cells, patient cell lines, and being able to specifically understand how these different variants in ASXL3 may be contributing to the disorder. And that way we can really understand how well our model systems are actually recapitulating what is happening in the actual patients. And so that gives us a lot of resources to then start to say, can we reverse any of these changes? Can we intervene on any of these changes? And that whole process does take time, but I think we're making progress, and we're actually new researchers are being attracted to the field, and that's an important part of growth for ASXL3 research.
Thank you. All right, we're going to go back to the clinical side of things here. So is there a connection with heart issues? Is this something we need to keep an eye on?
So we did ask for heart issues. The reason I didn't mention it is that it's not very frequent. So I'm not sure exactly, the heart does many things. So what I'm talking about are structural heart conditions where there are holes in the heart or requiring surgery. It can happen, but in a good way. It wasn't associated with very severe things where you needed open heart surgery. We weren't seeing a lot of things in terms of arrhythmias or heart rhythm problems or problems with cardiomyopathy or squeeze with the heart. So in general, I'd say it wasn't, someone may have something specific in mind, but we weren't seeing the heart as a major organ that was having problems. The other thing I just noticed in the chat, and Dr. Tan, I don't know, you may want to add something to this. He was saying that the mosaicism rate is way above 1%. So I stand corrected. I don't know if he wants to hazard a guess about how high that frequency is, but anyway, yeah. he's probably got more up-to-date numbers than I do.
Yeah, well, and his comment was specific to ASXL1, Bainbridge-Ropers Syndrome.
Oh, I'm sorry. I'm sorry, you're right.
Yeah, that's okay. Yep.
I also would just like to chime in relative to the heart, just because we analyzed the one of the mouse models. So it has 2 copies of ASXL3 mutated. So it's not like human patients. And we have a manuscript that's under review. So we may have a publication from my lab that suggests that ASXL3 mouse models will have a heart defect. But we don't think that that is actually, we've looked at a lot of the patient data, and while, as Wendy was suggesting, it doesn't seem like they're having a higher incidence than the normal population for a lot of the heart phenotypes that maybe that have been identified in individuals that have ASXL3 variants. So I'm just putting it out there. As Wendy suggested, all of the patients that have Bainbridge-Ropers syndrome only have 1 copy of ASXL3 that has a mutation in it. And the mouse models that may actually have a heart defect, they have 2 copies that are mutated. So I wouldn't, or that are changed. So just to put it in context, so no one freaks out and thinks that they should be worrying about heart failure or something like that.
Okay, so here's another research-oriented question, and you touched on some of this in your presentation, but I think this is a good opportunity to sort of do a summary here. So the question is, who can we talk to about getting our child involved in the research aspect of Bainbridge-Ropers syndrome?
I think Wendy gave the information for how you can join the Simon Searchlight cohort, and they are collecting clinical data and they're collecting biosamples, so mostly blood, but they're reprogramming some of those cells to many different kinds of cell types. And then Bianca Russell at UCLA, she has expanded to include all the ASXLs. She is also collecting clinical data, and she is also collecting biosamples. And I know you can link to her registry to our website, or search her up on Google, you'll find her. So I think that they're both great options, and your samples and your data will be compiled and be made available for not only researchers, but ultimately published for the families as well.
Great. And then the quick follow-up question to that is, can people outside of the US participate in these studies?
Absolutely. I think that the link that Wendy shared will work for any individuals outside of the US. And I know that Bianca has collaborators in Europe that also will allow for the same collection to be done in Europe, and those samples will be made available.
Thank you. Okay, and so the last question that we'll take here as we start to wrap up is a question about new technologies related to research. So how are the new technologies out there like mRNA, Cypher, CRISPR, how can those technologies help us find a treatment in the near future?
I think that it's the most exciting time to think about treatments and therapeutic interventions. The number of different options that are available are expanding, and how specific they can be and how they can be introduced into people's bodies are also, there's a lot of new options that are available. But I think the limitation is you have to know what you want to target, and not all ASXL3 variants are the same, and they may not function the same. And it will be really important to actually define that variability to know how we could potentially target ASXL3 to actually improve outcomes, as opposed to, we don't want to do any harm.
Wonderful. All right, well, thank you to our panelists for their questions here. We have a couple of final points here as we wrap up. I'm going to share my screen again here. Great. So as we close, I do want to share a couple of ways for you to get more involved with the R Foundation and stay up to date on the latest news about Bainbridge-Ropers Syndrome and ASXL disorders. So we are very eager to welcome your involvement with the R Foundation. We're funded entirely by families and organizations with a connection to an ASXL syndrome. And when you make a donation to the R Foundation, you're helping to advance the understanding of ASXL syndromes and supporting families through education. So there are a couple of easy ways that you can contribute. You can host a fundraiser on Facebook. It's very simple. You can do that right from the R Foundation Facebook page, or you can host a fundraiser in your community. If you shop on Amazon, you can select us as the beneficiary of the Amazon Smile program. And you can also include us in your family's charitable giving by making a donation directly. And we also have a growing monthly donation program called the Sustainer Circle. We also rely on volunteers to bring our programs and operations to life. We are seeking volunteers to help supplement our professional services, including IT infrastructure and support, legal advice, accounting, and communications. And we're also looking for program volunteers to help run our research grant program, plan our conference, and build our educational calendar of different programming options for families along the lines of today's program. So you can visit the Get Involved section of our website to learn more about how to help with fundraising or volunteering, or you can email me anytime. My email's there on the bottom of the screen, amanda@rfoundation.org. And finally, I invite you to connect with us. We publish a monthly newsletter and announce events like this one through our email list, which you can sign up for on our website. And I also invite you to follow us on Facebook, Twitter, and Instagram. So thank you so much for joining us today. And thank you, Dr. Bielas and Dr. Chung, for sharing so much of your time with us on a weekend, especially to help keep families up to date and share some wonderful information with them. All the participants, you will receive a link to a survey tomorrow by email to share your feedback on today's session. And we base our programming on family feedback. Those of you who participated in the family survey in February and March, you know, your feedback there helped make today's session possible. So we really appreciate your feedback and would welcome your input on this very brief survey. I think that'll do it for today. So thank you so much to everybody for joining us. Thank you to our speakers. Thank you to Elena for being our tech support in the background. She's been our wonderful intern so far this summer, and appreciate everything that everybody's doing to move this community forward. So thank you, everybody. Have a wonderful day.